In the last session, we had discussed about the management of hypovolemic shock with the crystalloids or the colloids solutions. Now, the last part in that is about the blood and blood products. As I told you, only in the fourth grade or beyond third grade of the shock, blood is indicated, and the blood in case of the hypovolemic shock, it's better that the whole blood is given. But now in the present day situation, you have the other choices also, the blood products. Of course, I am not going into the detail of these blood products. In the management of the shock, it's either the plasma, the fresh frozen plasma, can be given to enhance the volume of the blood chamber, that's to the hypolemia, but it doesn't carry the oxygen. With the plasma, the advantage over the colloid is unlike that of the colloids, it doesn't really get secreted. So it adds to the volume and remains in the circulation for quite a long time, and hence it will be very effective in maintenance of the volume of the circulation. So if the patient is having a very low blood pressure, to improve the blood pressure, and if it doesn't respond to the plasma expanders, plasma is given. But if the patient doesn't have the oxygenation properly and the tissue oxygenation is required, it has to be the fresh blood transfusion. Or to suppose you have managed the volume with the plasma expander, but only the oxygen carrying capacity has to be improved. In that condition, a packed cell also could be given. But better choice would be always the whole blood. And whole blood, usually the shelf life is around 35 days in 4 degrees centigrade. Whereas the other products, they may have the indications for the other products is something different, which we may discuss on some other day, in some other context. So as far as the hypovolemic shock is concerned, it's either the whole blood or the frozen plasma, or occasionally a packed cell could be the choices in such conditions. Of course, with the blood, the drawback would be to get the blood in a proper matched condition is again a technically difficult issue. Moreover, the complications it can occur could be there could be hemolytic transfusion reactions, febrile hemolytic reactions can occur, allergic reactions can occur, septic complications can occur if the proper the review of the blood is not done. Transfusion related lung injury, that's particularly if the volume is more, if a large amount of the blood is given, it can even result in edema of the lungs, circulatory overload, because it adds to the volume continuously. And if the cardiovascular system is already deficient, it can be uh, resulting in complications. If a patient already has a tissue graft, like a renal transplant or other graft conditions, giving blood transfusion can result in a reaction with that graft tissue, and the graft tissue can get rejected. And post-transfusion purpura also is a frequently occurring complication. Then, of course, with 1 or 2 units of blood, you may not have the iron toxicity. But if a large volume of the blood has to be given in repeatedly, then it can also result in iron toxicity. Now, the last part in that management would be management of the shock is when you can calculate the total volume of the fluid required by the initial Young's formula, which we have discussed in the previous session. Now, how much has to be given? The rate of infusion is the next point. Rate of infusion also is usually planned by the 4 to 1 rule. Now, 4 to 1 rule is the same which we have discussed in the context of assessing the total volume of the fluid required for maintenance. Similarly, in a patient where the bleeding has been stopped, if the bleeding has been stopped and you want to maintain the circulation properly, then the quantity should be for the first 10 kg body weight, 4 milliliter per kilogram body weight per hour into 10 kg, that's 40 ml per hour is given. And next 10 to 20 kg is 2 ml per kg per hour, 1 minute. Seven, 7 ಗಂಟೆ ಬರುವ. Next 10 to 20 kg is 2 ml per kg per hour. That's 20 milliliter per hour. So remaining 2 kg, 1 ml per kg per hour into 2 kg, that's 2 ml per hour. Good. And total hourly rate is 62 ml per hour. This is how the rate is given, rate of fluid infusion is done. That's example would be in an adult, a crystalloid of 5 to 10 ml per kg of colloid or red blood cells as bolus, it can be given as a bolus. Now, this is for initial stage, a patient who has already hypotension and you want to bring up the circulation immediately, instead of giving a single transfusion in terms of the drops per minute, you can give a bolus of 5 to 10 ml per kilogram body weight, push in large quantities, and then follow these management rules like the flow 40 ml per hour can be given. Now, when I say 40 ml per hour, it will be something like around 70 drops or 80 drops per minute, the rate. If it is 62 ml, it's around 120 drops per minute. So for 120 drops per minute, if you have to give a transfusion of 120 drops per minute, the cannula, IV cannula should be wider. It should be 16 number. In that usual 22 number, maximum could be around 80 drops per minute would be the maximum infusion rate. Whereas if you have to go for 120 drops per minute, the cannula should be wider cannula, or you may have to have a central catheterization. With the peripheral veins, it may not be possible. So to maintain that heavy rate, either you have to have a wider cannula, or maybe you may have to have a central venipuncture, central vein has to be punctured, or there could be a transfusion pump required. So with the usual general bar setup, uh, to go beyond 100 drops per minute would be not possible. Anyway, so that's how the shock has to be managed. Now, to confirm to whether the fluid given is enough or not, the criteria for recovery would be, one is the body weight. The body weight has to come back to the previous level, and the heart rate also has to be in the normal range, like it should be less than 80 per minute, and the blood pressure is one of the important criteria. The blood pressure should be near normal. And the most important criteria would be the orthostatic vital signs. That's if the patient has a patient in the erect posture, the blood pressure recorded in the lying down posture, the difference should not be more than 10 millimeters of mercury. Now that's a point which you have discussed in the previous session also. The one of the signs of the shock would be the postural hypotension, the difference in the postural pressure. If it is more than 20 millimeters of mercury, that's a sign that the circulation is affected, the patient is in a moderate shock. Now, during the recovery phase, it should be less than or not more than 10 millimeters of mercury difference. That's the systolic blood pressure recorded in the erect posture and the laying down posture. The difference should not be more than 10 millimeters of mercury. Then the other criteria is the respiratory rate. The respiratory rate should be within the normal range of around 20 per minute. Then venous and capillary reflexes, the same signs of the shock, they should be re-established. Urinary output is another of the important evidence. The urinary output should be at least 1 milliliter per hour as such. That's the amount of the urinary output which is required to prove that the patient has recovered from the shock. Of course, that continuous amount of the urinary output can be measured only when the patient is catheterized. If a patient is not catheterized, in that condition, that real-time urine output assessment is not possible. In children, the appearance of the fontanelle also. A child in a shock would have a depressed fontanelle, and once the child has recovered from the shock, the fontanelle will get its shape as such. Now, in extreme shock conditions, there could be a situation where if the patient is in a profound shock and the shock is persisting for a long duration, there could be one of the problem could be there could be severe vasoconstriction. Of course, in every patient of shock, there will be a vasoconstriction as a response. But in majority of the patients, once we start with the IV fluid, that vasoconstriction gets corrected itself and the patient may recover. But in rare conditions, in very rare conditions, particularly in the patients who are in shock for a long duration, and quite frequently in children, this occurs in pediatric conditions too, The vascular resistance, that vasoconstriction, can remain as such even after giving blood transfusion, these IV fluids. The fluid may get into the circulation, but the blood vessels may remain constricted. Now, the problem in that condition would be you may see that blood pressure is normal. The patient may have a blood pressure which is normal. The systolic blood pressure may rise, but diastolic blood pressure would be very low, resulting in a very high pulse pressure. But that doesn't result in the tissue perfusion. Patient may not have the signs of recovery in terms of the tissue appearance. There could be the visible signs of the shock still persisting, even if the circulatory pressure is normal. And hence, in such conditions, uh, you may have to give a vasodilator. Now, this is a paradoxical situation. In a shock, it's always that the vasoconstrictors are required, and of course, in a toxic shock or the next distributive shock conditions, we'll discuss about the vasoconstrictor drugs and all that in detail. So, in general, it's the vasoconstrictor drugs are required, but in such as a rare conditions where the patient's blood pressure may recover, but the tissue perfusion doesn't recover, in such conditions, a vasodilator may have to be given, and the usual vasodilators given are either nitroglycerin at 5 micrograms per minute rate or dopamine. Now, it is a very interesting dopamine. We'll be discussing in detail about dopamine in the next session. Now, dopamine in very low dose acts as a vasodilator, whereas in a relatively higher dose, it acts as a vasoconstrictor. That again, we will discuss that somewhat in detail later. In dopamine given at a low dose of 1 to 4 micrograms per kilogram per minute also can be given such conditions. Or milrinone, which is another of the new drug which is a vasodilator, and the dose is again 0.4 to 0.6 micrograms per kilogram per minute after loading dose, and then can be maintained at a 50 micrograms per kilogram as such. That's about the hypovolemic shock and its management. The next part is about the distributive shock. Now, when I say distributive shock, that means the total volume of the circulating fluid remains same, but there would be a dilatation, the vasodilatation. The total volume of the circulating chamber has become increased due to sudden vasodilatation. When the blood vessels become dilated and the volume of the circulating chamber is enhanced suddenly, and there is no such coping up of the volume of the blood into that chamber, then it results in a distributive shock. Of course, in a normal situation, there will be always a reserve volume of around 700 ml, which remains static, which doesn't come into the active circulation. In general, we say that the total volume of the blood is considered to be 5000 ml, but all 5000 ml doesn't come into the circulation. Around more than 700 ml of the blood remains static in the venous chambers, and whenever there is a sudden change in the circulation, that static volume adds to the volume and maintains copes up with the circulating needs. So, average vasodilatation which occurs due to day-to-day activity doesn't result in a shock. But if there is a significant dilatation and this volume which is static doesn't cope up with the circulation as such, that results in a distributive shock. Now, when I say distributive shock means, in summary, maybe in a different language, the total volume of the circulating fluid has not reduced. It's only the volume of the circulating chamber has increased, and that results in a imbalance between the volume of the circulating chamber and the circulating fluid, which results in a low pressure. Now, this low pressure can result in it, different sorts of the complications. At areas, some areas of the body, the blood may not flow and blood may remain stagnated. Some areas, particularly in the gravitational dependent area, the blood may remain stagnated and it will not move. So there are maybe in the gravitational dependent area, you may see the signs of increased blood flow there or vascular stasis. In some other areas, there could be emptiness. The blood may not be reaching to the vessels, particularly in the gravitationally superior area. In that area, there could be emptying. Vessels will be emptying. There will be no reach of the blood itself. Or it could be like the blood may be flowing very slowly and it doesn't produce sufficient oxygenation. Or at times, in some areas of the body, in such situation, there could be very fast movement of the blood, and that fast movement of the blood also would not be enough to maintain the oxygen exchange. Now, the whole point is that the changes which occur in the body would not be uniform. In some areas, the response is that the situation is there is no blood flow at all. In some areas, the blood gets stagnated. In some areas, blood flows rapidly, and this makes the issue of distributive shock more difficult to manage, or issues will be more difficult to manage, and the approach to the treatment will be different. Now, causes for this distributive shock, the most common is anaphylactic shock. Anaphylactic is a sort of allergic reaction, when hypersensitive reaction, when due to the release of the tissue amines produced through the allergic reaction, there could be vasodilatation, and that vasodilatation results in a distributive shock as such, or adrenal insufficiency, Waterhouse-Friderichsen syndrome, a sudden hemorrhage into the adrenal gland, and the adrenal gland fails to produce actions. In such conditions, it can result in a distributive shock. Or reactions to drugs or toxins, acute drug reactions, also can result in a distributive shock, which is just a variation of the anaphylaxis. See, in the anaphylaxis, it's a hypersensitive issue. Drug reactions means due to the adverse effect of the drugs or the toxic substances, there could be dilatation. Similarly, heavy metal poisoning. Heavy metal poisoning also can result in a similar issue. It's also a toxic reaction. Acute hepatic insufficiency. Acute hepatic failure also can result in a shock-like state. There are neurogenic shock. Neurogenic shock is due to the pain stimulus. Acute pain stimulus during surgery or otherwise, due to or maybe trauma, that pain itself could be resulting in a vasodilatation and a distributive shock can occur. Another quite common and significant condition in the clinical practice would be sepsis. Any infective pathology, very often pulmonary, respiratory infections, pneumonia-like patients, or it could be any other complications can occur, and this can result in a distributive shock. Then there is another unique condition called as systemic inflammatory response syndrome. Due to any inflammatory disease in the body, even autoimmune diseases can result in that. Now, systemic inflammatory response syndrome is a unique issue. Of course, this has become quite popular with the COVID and related issues. The typical clinical signs would be the core temperature would be very high, like 38 degrees centigrade, or it could become lower, less than normal. Heart rate is often more than 90 beats per minute. Respiratory rate, there will be always a tachypnea, and the arterial carbon dioxide. This is important. Wherever there is a possibility of measuring the carbon dioxide, the carbon dioxide level will be lower, and white blood cell count will be much more than 12,000, or at times it could be lower, a very low, like less than 4,000. So extreme variations of these can occur, and the systemic inflammatory response syndrome can occur due to any infection, burns, after surgery, trauma, and quite important is pancreatitis. Acute pancreatitis can result in a shock-like conditions where there would be a tissue digestion due to the enzymes from the pancreas reaching to the circulation. Or acute hepatic failure also can result in the same. Now, clinical signs of a distributive shock is one is the change in the mental status. Patient may become delirious or even semi-conscious or unconscious. Heart rate is essentially more than 90 beats per minute, and if the patient is already on a beta blocker drug, if the patient, like very often which occurs in patients of cerebrovascular accident, etc., where the patient may be in a beta blocker drug, in that condition, heart rate may not be a criteria. Systolic blood pressure is less than 90 millimeters, or a reduction of 40 millimeters of mercury from the baseline. If compared to the previous blood pressure recording, normal blood pressure recording, there would be a reduction of at least 40 millimeters of mercury of systolic blood pressure. Respiratory rate, there will be a tachypnea. Extremities, unlike that of a hypovolemic shock, in a distributive shock, extremities will not be cold. Now, this is due to the vascular stasis, and there could be warm, or even there could be a bounding pulse. Now, That's the basic difference in the clinical evidence of a hypovolemic shock and the distributive shock. In a hypovolemic shock, a cold clammy limbs and 3D pulse are the signs, whereas in a distributive shock, the extremities may remain warm or normal and the pulses may be bounding. You may be still able to feel the pulse or the pulse pressure may be even increasing. The diastolic difference between the systolic and the diastolic pressure would be more. And in the late extreme severe conditions only, the pulse pressure may fall and the circulatory pressure may fall, and that's a sign of extreme severe conditions. In the moderate varieties of or moderate degrees of distributive shock, you may not see these pulse pressure or the signs of peripheral circulatory failure. Instead, there could be a peripheral circulatory stasis and hyperthermia. The core body temperature would be always higher, or extreme conditions, severe conditions, it could be lower than normal. Hypothermia also could be there. If you do the pulse oximetry, there could be hypoxemia. The total oxygen concentration would be lesser. Urinary output also would be lesser in case of a distributive shock, particularly septic conditions. Now, these clinical signs are very much the clinical signs of the Ojo Nirodha Vyadhi or Ojo Vibhramsha. Ojo Vistramsa, Ojo Vistramsa, Pitta Anila Symmetrias, Gatrastamba Shitabhyam, that Gatrastamba Shitabhyam, Shainepsuha, Chetanaha, Abhi Jagrat Swapan Jatu Jantu, Tandrarushcha Pralapavan, Samsasaroma, Srastangaha, Manda Santapa Vedanaha. These are the typical signs of audio vibramsha. Now, the whole distributive shock has to be managed on the lines of maintaining a proper pituitary adrenal axis, and function of the pituitary adrenal axis has to be taken care of. Now, we will continue with this in the next session. Today, I have to leave and we will conclude today. Right.
Thank you,
Thank
sir.
you.